Good afternoon. My name is Marlise Luskin, and I will be giving the lecture today on leukemia and myelodysplastic syndrome. I'm an assistant professor at Harvard Medical School and a physician in the adult leukemia program at Dana-Farber Cancer Institute and Brigham and Women's Hospital. I have no disclosures to report. This is an outline of what I'll be discussing today in my review. I'll be covering basics of acute leukemias, acute myeloid leukemia, and acute lymphoblastic leukemia, as well as basics of chronic myeloid neoplasms, which include myelodysplastic syndromes, myeloproliferative neoplasms, and overlap syndromes, MDS, MPN overlap syndromes. I'd like to start with an overview of how I think about leukemia. And I think about leukemia in sort of two different categories. I think about myeloid diseases and lymphoid diseases. And then within those two different categories, I think about acute diseases, where there's an increased number of blasts or immature cells. Those are acute diseases for which there is two forms, acute myeloid leukemia and acute lymphoblastic leukemia. And then we think about more chronic, more indolent diseases, which include chronic myeloid diseases, which include MDS, MPN, and overlap syndromes, MDS, MPN. And then the more chronic lymphoid diseases, which are lymphoma and plasma cell disorders, which will be covered in different presentations of this series. Be aware that the term leukemia often is just used to refer to any blood condition with a circulating component, and some lymphomas can have a so-called leukemic phase. And so it's important to know that leukemia is a general term for blood cancer, and among leukemias, there's many different forms in the myeloid and lymphoid space. The first disease I'm going to talk about is acute myeloid leukemia, and we'll talk about what is that diagnosis. The diagnosis of acute myeloid leukemia occurs when there are more than 20% myeloid blasts in the bone marrow aspirate or in a blood count. This is primarily a disease of increased immature blasts in the bone marrow and blood, but occasionally this disease can be found outside the medullary space, so-called extramedullary AML. And there are times when certain aberrations, certain genetic aberrations lead to a diagnosis, even if there are less than 20% blasts. Blasts are identified morphologically under the microscope, and they have characteristic appearance. There's an example here on the side of the screen. Blasts are usually large cells with large nuclei, open chromatin, scant cytoplasm, so-called high N to C ratio, and often there's prominent nucleoli visible as well. Our rods are seen in myeloid blasts and are lineage defining and tell the viewer that just by looking at the smear that those blasts are considered myeloid blasts. However, in general, the lineage of a blast requires immunophenotyping or flow cytometry to confirm that they're blasts or immature cells and that they're myeloid versus lymphoid. AML is a relatively rare condition. There are about 20,000 cases diagnosed each year, and it composes only about 1% of all new cancers diagnosed. You can see an age distribution in the center graph, and this is primarily a disease of older adults, present in all age ranges, but with a peak diagnosis in the 60 and 70 age range, with a median age of diagnosis of 68 years. Risk factors for developing this condition include being older, as I mentioned, as well as exposure to radiation and other chemotherapy. And patients with AML often have a prior myeloid disorder, such as MDS or MPN. AML there are various prognostic features that determine how well a patient with a diagnosis will do with treatment. And the main considerations include age, with older adults have inferior outcomes to younger adults, the context in which the disease develops, specifically whether the disease came out of the blue with no prior blood history, versus patients who have prior chemotherapy, so-called therapy-related AML, or a prior diagnosis of MDS or a myeloproliferative disorder, which is so-called secondary AML. The therapy-related and secondary AML have a poorer outcome than those who have de novo disease. And then thirdly, the third main consideration in determining prognosis in AML are the genetics, or abnormalities in chromosomes and mutations in specific genes. There are a group of genetic aberrations that are associated with a favorable prognosis, as listed here in the slide, as well as a group of mutations or abnormalities that are associated with a particularly poor prognosis. And then, of course, there are abnormalities that are in the middle. The graph to your upper right shows the survival curves for different abnormalities, and as you can see, there's a wide variety of outcomes based on what the genetics are at diagnosis. To be clear, these are what we call so-called somatic genetic abnormalities in the disease itself, and not genetic abnormalities that are inherited or passed on in the germline. Approach to therapy for AML has two phases. The first phase is to induce remission with chemotherapy. The goal is to reduce the amount of leukemia to undetectable levels, which is called a complete remission, meaning that the blasts are down to a normal level. Ideally, patients who have remission also have recovery of their normal blood counts. The second phase of treatment is to try and consolidate that remission, which can either be with the goal of cure, i.e. getting rid of the remaining disease that is present at undetectable levels so that it never returns and the disease is cured, or to at least maintain that disease at a minimal disease state for as long as possible to extend survival. The choice of therapy is based on the characteristics of both the patient and the disease. It's important to define the goal of therapy, whether the goal is to try and cure the patient or really whether the goal is to try and just control that disease. And then to understand the patient's ability to tolerate therapy, intensive therapy versus less intensive therapy, and the relative expected response of that disease to therapy based on the prognostic characteristics that I mentioned in the previous slide. And of course, the patient's preferences and goals are important to factor in as therapy is chosen. The specifics of therapy are nuanced, but in general, we divide chemotherapy into various categories. So-called intensive chemotherapy or traditional cytotoxic chemotherapy includes, for many years, has been really based on the combination of daunorubicin and cytarabine, so-called 7+3. And this is the AML that's been used for many years. There are some variations on that treatment called Vyxeos, which is a liposomal formulation. And then there are less intensive therapies listed in the slide, as well as targeted therapies that are used for specific diseases. As mentioned, the first goal of therapy is to achieve remission, and one of the therapies mentioned in the previous slide is selected as the best choice for that patient. And then if that therapy is successful and the patient achieves remission, consolidation is pursued with the goal of cure or to extend that remission. That can either include more cycles of chemotherapy, which is usually something called cytarabine, or in certain patients who are younger and healthy, something called allogeneic transplant, which is used to try and cure patients with high-risk leukemia. High-risk leukemia can either be patients who are older, have high-risk genetics, or as mentioned before, the secondary therapy-related AML. For patients who are not being treated for cure, continuation of their low-intensity therapy can help extend that remission. Just briefly, a note about transplant. Hematopoietic stem cell transplantation is a type of transplant where a patient's blood system the goal is to replace that patient's blood system with a blood system from another patient that's allogeneic as opposed to autologous, which is from one's own system. And the concept is that a patient receives chemotherapy conditioning to make room for donor cells in the bone marrow. And then donor cells, stem cells from a matched donor are infused and engraft and create a new blood system, which is associated with a new immune system, which can be effective at targeting residual leukemia or leukemia that tries to return. This is something termed the graft versus leukemia effect. There are different types of transplants, including more intensive, so-called myeloablative transplants, that is usually reserved for younger patients given the intensity of the chemotherapy, and then so-called non-myeloablative transplants or reduced transplants that are able to be applied to older patients and really rely specifically on the effect of the donor cells as opposed to the conditioning chemotherapy. The risks of transplant include chemotherapy toxicities, the immune suppression that's required to help the new donor cells adjust to the new host environment, and the risk of opportunistic infections, and then a disease called graft versus host disease, where the new donor cells can attack the patient's own organs, including the liver, skin, and gastrointestinal tract. There is one particular type of AML that deserves mention. This is something called acute promyelocytic leukemia. And this is a really important subtype to remember and to mention. Although it's rare, it is a disease where the treatment team, the physicians, have really an opportunity to change the natural history. As mentioned, AML in general is a rare disease with about 20,000 cases per year. Only about 10% of those cases are acute promyelocytic leukemia, but these patients are treated very differently and have a high risk of early toxicity, but also the opportunity to cure this if these patients survive the initial phases. So this is a subtype of AML that is defined by a particular genetic abnormality, the rearrangement between chromosomes 15 and 17, the 15-17 translocation, that fuses two genes, PML and RAR alpha. And this genetic abnormality leads to a type of AML that has a very high rate of coagulopathy, or DIC. And that DIC can lead to bruising and bleeding, and in particular risk of intracranial hemorrhage. And so when this disease is diagnosed or suspected, urgent treatment is needed to try and avoid that complication. This type of AML often presents with low blood counts, pancytopenia, as well as DIC, and can be suspected by certain appearance of a blast, including frequent hour rods and granules, and has a particular pattern on flow cytometry, as listed in this slide. When this disease is suspected, immediate treatment is recommended with supportive care, including blood transfusions to treat the coagulopathy, as well as administration of a particular type of chemotherapy called ATRA, which can begin to treat the APL and stabilize the complications, prevent ongoing DIC. The diagnosis is confirmed by confirming that characteristic abnormality, the 15-17 translocation, or the PML-RAR fusion. If patients survive the initial diagnosis and the initial days of treatment, and they survive the initial blood coagulopathy, the cure rates for this disease now are very high, approaching 90 to 100%. Now we'll move on to acute lymphoblastic leukemia, which is the other form of acute disease. Remember, the acute leukemias are characterized by an overproduction of blasts or immature cells. AML was the overproduction of myeloid blasts, and acute lymphoblastic leukemia is the overproduction of lymphoid blasts. This disease is often referred to as acute lymphoblastic leukemia, but if the disease is only present outside the bone marrow space, it is often referred to as LBL, or lymphoblastic lymphoma. These are the same diseases and are treated similarly. Patients often present with low blood counts or collections of the lymphoblasts in other organs, causing adenopathy or swollen lymph nodes, and also can be infiltrations of the mediastinum, mediastinal mass, and the central nervous system. Patients can present with constitutional symptoms as well. The diagnosis, as with AML, is confirmed by identifying blasts under the microscope in either the blood or the bone marrow, and then confirming the immunophenotype by flow cytometry, namely that they are blast immature cells and that they express lymphoid markers. And ALL can be either B-cell lymphoblastic leukemia or T-cell lymphoblastic leukemia based on the markers that they express. This is an even rarer condition than AML. The prevalence in the US is only about 6,000 patients per year, so even less than AML. And the age distribution is also different than AML. This is a disease that is seen very commonly in young people. About half of the cases of ALL are diagnosed in children, although half the cases are seen by adult physicians. Although half the cases of ALL are diagnosed in adults, the outcomes for adults with ALL are far inferior to those in children. The majority of children are now cured of their diagnosis, whereas the outcomes for older adults are much decreased. The prognostic features for ALL include age, genetics, how high the white blood cells are at presentation, the involvement of the CNS, and how the patient responds to initial therapy. These are similar prognostic features to what we saw in AML, though there are some differences in the details of the prognostic features for both those diseases. The approach to ALL is really guided by two things. One is whether or not there's whether the patient has something called a Philadelphia chromosome, which I'll explain in just one moment. And then, as with AML, their age and fitness for chemotherapy. The Philadelphia chromosome is a particular genetic abnormality where there's a rearrangement between chromosomes 9 and 22, as shown in the picture. That places a gene called ABL next to a gene called BCR, and this leads to the constitutive activation or overactivation of the ABL gene, which is a kinase, and that's essentially like an on switch that drives proliferation. This is important because we now have drugs, including inhibitors, specific pills that target that overactive kinase and can decrease its activity. And it's been found that when those drugs are combined with chemotherapy, there were far improved outcomes, and there's been the ability to decrease the intensity of chemotherapy. For patients who do not have that particular abnormality and the ability to use those targeted therapies, the standard treatment is multiple cycles of combination chemotherapy. ALL regimens are complex regimens that use numerous agents in combination at different doses and schedules. And the core drugs include drugs called vincristine, which is a microtubular inhibitor, steroids, and anthracycline. All patients also need CNS prophylaxis, as ALL has a tendency to involve the central nervous system. And so patients receive CNS treatment regardless of the presence of disease at presentation. These patients need long courses of chemotherapy, up to 2 or 3 years, and the intensity of therapy is tailored based on the age of the patient. So young patients should receive, we call pediatric inspired or adolescent young adult regimens that are based on how pediatricians treat their patients, pediatric protocols. And these are intensive regimens that include a escalated number of steroids and a drug called asparaginase. Older patients receive dose-reduced chemotherapy, and there's a lot of interest in applying new therapies or so-called novel agents for these patients who do not tolerate traditional chemotherapy well. For many years, there were not new treatments for ALL, but there are now a lot of new therapies now available for relapsed ALL, as listed in the slide. Now, I will not spend much time on it speaking today. They are included here for your reference. And then finally, before we close this section on acute leukemia, it's important to remember the so-called oncologic emergencies that occur with these diseases. Acute leukemias are very aggressive cancers, and often patients present very sick with particular complications that need aggressive management, usually in the hospital. These include febrile neutropenia, or infections in the context of a very low neutrophil count, which can lead to very severe infections and sepsis if not addressed aggressively. Tumor lysis syndrome, due to the high proliferative rate of these cancers, which often require management for hyperuricemia, other electrolyte derangements, and kidney failure. Disseminated intravascular coagulation, or DIC, which can happen with either ALL or AML, and particularly prominent in the subtype of AML termed acute promyelocytic leukemia that we just discussed. And then complications of very high white blood cell count. Hyperleukocytosis is a lab abnormality defined by the presence of very high white count, in particular very high blast count. And then leukostasis is the clinical syndrome that accompanies some cases of hyperleukocytosis, where those blood cells start to affect the function of organ, including the brain, leading to confusion, the lungs, leading to low oxygen levels, and the heart, leading to cardiac ischemia or compromise. This is managed with attempts to get the white blood cell count down quickly, including treating with hydroxyurea, which is an oral chemotherapy that leads to decrease in the white blood cell count. Occasionally something called leukapheresis, where the white blood cells are decreased through physical removal through the pheresis procedure. And then attention to other supportive care, including hydration and avoidance of transfusions while the white blood cell count is very high. It's important that anybody with a new diagnosis of AML or ALL be assessed for the presence of these complications and be managed aggressively. Now we'll move on to the chronic conditions, the chronic myeloid conditions, and we'll start with myelodysplastic syndrome, which is a group of myeloid lineage neoplasms, which are really defined by ineffective hematopoiesis or ineffective production of blood cells. So the diagnosis of MDS requires the identification of low blood counts in at least one of the three lineages: white blood cell count, red blood cell count, and platelets. And then identification based on bone marrow biopsy of a non-functional or a malignant bone marrow, so-called MDS defining abnormality, which can include dysplasia, a particular genetic abnormality or cytogenetic abnormality, or the presence of excess blasts or extra blasts that don't meet criteria for acute myeloid leukemia. It's important to remember that dysplasia is nonspecific and also may be due to other causes of cytopenias, including medications or illness. And so the patient's clinical context must also be considered when making this diagnosis. So the hallmarks of MDS include the risk of progression to AML, bone marrow failure or the lack of production of blood cells or cytopenias, and clonality, meaning that this is a cancer. Although it's sometimes referred to as pre-leukemia or a blood condition, this is technically a cancer, given its malignant, based on the fact that it is defined by mutations and malignant clonal abnormalities. MDS has a widely varied presentation and risk of progression, and some patients have very mild abnormalities and are completely asymptomatic, while others experience substantial symptom burden. MDS is a disease of older adults, as shown here in this picture. The median age is 76 years, and the prevalence of this disease increases with each decade. Very rare in pediatrics and young adults, and becomes more common in the 60s, 70s, and 80s. It's likely underdiagnosed as well, and underreported to cancer registries, and so the true prevalence is likely higher than is reported in various publications. Some registries report about 10,000 new cases per year. Risk factors include older age and prior chemotherapy and radiation. As I mentioned, the prognosis and the severity of MDS varies widely, and this is assessed through something called the IPSS, or the International Prognostic Scoring System. And this scoring system was developed to help predict how aggressive an individual case of MDS is likely to be, and includes and integrates various disease features, including the number and degree of cytopenias, the presence and degree of excess blasts, and the particular karyotype or genetic risk. The IPSS was the original scoring system, and there are now revised versions of this as well, refining the various categories. And these scoring systems can predict the natural history, the risk that the MDS will progress in terms of further cytopenias and progression to AML, or the acute phase of the disease. MDS is treated based on the risk. So supportive care in terms of managing the effects of low blood counts is applied to all patients who need it, and it can include transfusions or growth factors, something called erythropoietin, to help improve anemia. Patients who have high-risk disease are considered for so-called disease-modifying treatment, trying to affect the progression of the disease with chemotherapies, including something called azacitidine or decitabine. And for patients who are young with very aggressive disease, allogeneic transplant, which was discussed for AML, is also considered. As with all the diseases, defining the goal of therapy, determining the aggressiveness of the cancer, and the ability of a patient to tolerate treatment, particularly in older adults, is important. Now we'll talk about chronic myeloid leukemia, which is another chronic myeloid neoplasm. This is now in the myeloproliferative category as opposed to the myelodysplastic category. Myeloproliferative neoplasms are characterized by the overproduction of cells. In this case, proliferation of mature and maturing granulocytes. This disease is defined by the presence of the Philadelphia chromosome, which we mentioned is also present in some cases of ALL. In CML, all patients have the Philadelphia chromosome. Patients are often either asymptomatic or have mild symptoms, including fatigue, malaise, weight loss, abdominal pain and fullness due to splenomegaly, and that splenomegaly may be appreciated on exam. There are characteristic blood smear abnormalities and characteristics of the marrow as listed here, and often this disease can be suspected based on the initial blood counts, but is then confirmed by the presence of the Philadelphia chromosome. The CML is defined by that Philadelphia chromosome and that overactive Abl tyrosine kinase, and this leads to the uncontrolled proliferation of the granulocyte lineage. This is a rare condition, about 9,000 cases per year, and is diagnosed in adults of all ages with a peak in the 50s and 60s. This disease has seen dramatic improvements in survival over the last several decades, such that although this is a rare disease, the prevalence is increasing each year, such that over 50,000 patients in the US are living with CML. The natural history of CML is divided into a biphasic or triphasic course. Most patients are diagnosed in so-called chronic phase, and these are patients who are discovered incidentally or with just mild symptoms. And these patients often feel quite well with relatively indolent behavior. If the CML is not treated, eventually the chronic phase CML will transform into an accelerated or blast phase form where there are excess number of blasts, such that the disease resembles an acute leukemia. Untreated, this would happen within 3 to 5 years. In the modern era, we are able to treat most patients such that most patients stay in chronic phase disease for their entire life. The approach to treatment for CML is for even asymptomatic patients are treated to prevent that transformation. And most patients almost all patients receive treatment with a tyrosine kinase inhibitor. Imatinib was the initial tyrosine kinase inhibitor that was developed for CML and really transformed the prognosis for CML. Now, TKIs are the primary modality for therapy and really transform this disease from a fatal condition or a condition that required a transplant to one where patients now have an essentially normal life expectancy and just require taking a pill once per day for their life. We'll wrap up this brief talk on leukemias by mentioning the Philadelphia chromosome negative myeloproliferative neoplasms. So CML was a myeloproliferative disorder, an overproduction of cells characterized by the particular abnormality termed the Philadelphia chromosome. The rest of the myeloproliferative disorders are considered pH negative disorders, and these include a number of diagnoses that are associated with overproduction of other types of cells. So all of these conditions are associated with the overproduction of one or more mature myeloid cells, and they have different mutations that drive their phenotype. These include essential thrombocythemia, polycythemia vera, and myelofibrosis, and they commonly have mutations in JAK2, MPL, and CALR. These are generally indolent disorders that can progress, though, to more of a fibrotic phase in myelofibrosis, or as with CML, untreated to a more acute, accelerated phase, acute leukemia. Low-risk patients are generally observed and just employed supportive treatment. ET and PV is associated with an elevated risk for thrombosis, which is managed with aspirin, phlebotomy, and then hydroxyurea for high-risk patients. And patients who are showing signs of accelerated disease are considered for chemotherapy and transplant. And then finally, what is an MDS-MPN overlap syndrome? These are diseases that have features of both MDS and MPNs, dysplasia cytopenias like the MDS, and cytoses or elevated counts like the myeloproliferative disorders. The most common example in this group of diseases is chronic myelomonocytic leukemia, or CMML, which has an acronym very similar to CML, but is an entirely different disease. Management of overlap syndromes is extrapolated from the management of MDS and MPN. Listed here are a few references. I'd like to thank my disease group for for all of the education that they've taught me about these diseases. And we'll move on to the questions. Question 1. A 54-year-old male presents with a white blood cell count of 230,000. He denies bruising and bleeding. On exam, he has a large spleen. His hemoglobin and platelets are normal. A bone marrow biopsy demonstrates chronic myeloid leukemia. What is the hallmark chromosomal finding of this diagnosis? The answer is the 922 translocation, which is the Philadelphia chromosome. This translocation is required for the diagnosis of CML, though it's also seen in a subset of cases of ALL. The MLL translocation is an abnormality seen in AML and ALL, but not CML. The 1517 translocation defines acute promyelocytic leukemia, or APL, and loss of chromosome 7 can be seen in a number of myeloid disorders. Question 2. A 26-year-old female presents after 2 visits to the ER for heavy vaginal bleeding. This has not improved with typical management. A blood count is checked, and this shows pancytopenia and abnormalities in measures of coagulation, including a low fibrinogen and an elevated INR. Review of her blood smear shows immature cells with abundant Auer rods. What is her most likely diagnosis? This patient almost certainly has acute promyelocytic leukemia, a constellation of low blood counts, clinical coagulopathy, including heavy menorrhagia, and laboratory evidence of coagulopathy is suggestive of APL. The blood smear is also consistent in that there are immature cells, which is blasts, with abundant Auer rods, which is not specific for, but very common with APL. Based on this information, she should be managed as acute promyelocytic leukemia with initiation of ATRA, and the diagnosis would be confirmed by confirming the presence of the 1517 translocation or the PML-RAR transcript.